Hello and welcome to our webinar. I'm Dr. David Young from Flagship Biosciences, and today's webinar topic is improving PD-L1 scoring with image analysis. I'm very pleased to introduce Dr. Roberto Giannani, Flagship's Medical Director, as our speaker. Dr. Giannani has a wealth of experience in tissue biomarkers associated with immuno-oncology therapeutics and in image analysis of these biomarkers. Before we get started, I wanted to go over a few housekeeping items. First, you are in listen-only mode, and you will hear the presentation via your computer monitors and speakers. Secondly, you can submit questions at any time using the questions box, and we encourage you to submit questions during the presentations. We will have a time at the end of the presentation for a question and answer session. And finally, today's presentation is being recorded and will be available within 48 hours. We will send you a link via email. So with no further housekeeping items, it is with great pleasure that I turn the presentation over to Dr. Giannani.
Good morning or good afternoon. Thank you, and let me start the presentation. So we are going to review the checkpoint inhibitor therapy with a focus on PD-1, PD-L1 therapy. We are then going to look at the challenges with the current scoring paradigms and propose some solution to these challenges utilizing Flagship expertise. Finally, we will have some time set aside for question and answer. So let's start with the overview of the history and status of checkpoint inhibitor therapy with a special focus on PD-1, PD-L1. As you can see from this illustration, PD-L1, PD-1 interaction occur when the PD-1 on the T cells bind the PD-L1 on the tumor cells after the TCR has engaged the antigen produced by the tumor cells in the context of MHC molecule. These neotumor antigens are often the results of mutation and mismatch repair deficiency leading to frameshift mutation. In the absence of an antibody to PD-L1 or to PD-1, the PD-L1 PD-1 interaction produces T cell energy. However, in the presence of one of these antibody, T cell activation can occur, and the tumor is free to kill, and the T cells is free to kill the tumor cells. The system, however, is more complex than that because there is expression of PD-L1 and PD-1 also on adjacent tumor cells. An engagement of PD-1 by PD-L1 can result in trophic signals. This slide illustrates that the field of checkpoint inhibitors is, after all, a fairly young field. It was only at the turn of the last century that the concept of immune surveillance was introduced. And it wasn't until the early 2000s that the discovery of CTL4 specific antibody identification of two ligands, PD-L1 and PD-L2 for PD-1 was discovered. Despite the fact that there's been a fairly short amount of time, there's been an explosion of knowledge in this field, and now there are several clinical trials based on humanized monoclonal antibodies to either PD-1 or PD-L1 or both. Predicting the outcome of anti-PD-L1 therapy is very important because anti-PD-L1 therapy is expensive. It has a potentially damaging side effect, mostly autoimmune disease, and therefore it's critical to utilize this therapy in patients most likely to benefit from it. In addition, some data indicates that a subset of patients respond very well to anti-PD-1 therapy with prolonged survival. However, the mechanism of this response is unclear, and deeper characterization is necessary to potentially extend this benefit to other patients. To date, these goals have been largely attempted by creating antibodies targeting PD-L1 and designing scoring paradigms associated with these antibodies, based on their ability to predict response. As we were actually alluding to earlier, there are now a number of clinical trials utilizing PD or PD-L1 or both, either by themselves or in combination with more traditional therapy. Let's delve actually now in the part of the talk where we illustrated the challenges with the current scoring paradigms. So, many immunohistochemical anti-PD-L1 and PD-L1 and PD-1 IVD are on the market, and those are associated with on-label manual and scoring paradigms. This scoring is often highly complex. The complexity of the scoring reduces the reproducibility, as well as the intra and interpathologist concordance. And this in turn determines a loss of confidence in the data and in the patient selection. We propose that the solution to this problem is image analysis scoring. Let's look at more in detail at what are the challenges of manual scoring paradigms. We summarize this in 5 points. Number 1, the accuracy challenge. In other words, can the pathologist be accurate enough around the cutoff points to prevent erroneous classification of the staining? Number 2, the practicality challenge. It takes considerable time to score these slides, as well to ensure consistent training across pathologists. Number 3, the oversimplification challenge. The scoring paradigms do not really take in account the heterogeneity of the tumor microenvironment. Number 4, the spatial challenge. Current paradigms do not consider the spatial localization of the staining and the spatial relations of the cells. Number 5, the utility challenge. This is a big one and deserves its own slide. Let's start with the utility challenge. This is the biggest one, and the underlying assumption in performing PD-L1 immunohistochemistry on tumor section is that we can just use the analysis of the slide, and in particular the PD-1, PD-L1 immunotherapy, immunostaining, by quantifying PD-L1 staining. In reality, many different factors contribute, not exclusively the checkpoint inhibitor, to the type of response to foreign antigens, including tumor antigens. More sophisticated data collection and processing, as well as the integration of flagship data with next-generation sequence to calculate the tumor mutation burden, proteomics, and other modalities, may provide the information needed to improve the predictive value of the test. This slide, I'm not gonna go in detail in this slide, but it's here for your information. But basically, I want to illustrate the point that there are at least 4 antibodies for PD-L1 on the market with different indications and method for determining positive or negative status or low or high status. 22C3, SP142, 28, 28-8, and SP263. Now, the scoring paradigm is not only changed from one antibody to the other, But sometimes it changes also in the context of the same antibody as one changes indication. So there is, in summary, a great deal of complexity and a lot of information for the pathologist to keep track of. Let's look at an example of this challenge. And let's focus for a moment on one of these antibodies, which is sp263. So first you identify the tumor area, then you identify and estimate the percentage of PD-L1 positive tumor cells. If the tumor cells is above or equal 25%, then you can declare the PD-L1 slide to be PD-L1 high. However, it gets more complicated because there is another way to reach the status of PD-L1 high that goes by the estimation of the ICP and the estimation of the IC, i.e. the percentage of tumor occupied the tumor cells and the percentage of tumor occupied by immune cells and the percentage of immune cells positive for PD-L1. And this is again another alternative pathway to reach the PD-L1 high. If none of these criteria is satisfied, then the slide is declared PD-L1 low. So there are many decision points and high degree of complexity. It's a challenge to achieve concordance with such a scoring paradigm, as anybody that has attempted to do this large-scale screening can testify of. Now, flagship actually biosciences can reproduce all of these scoring paradigms by image analysis. This is actually, this slide represents an example of what of the typical workflow the flagship would do when we are presented with a PD-L1 score, a PD-L1 stain slide, or for that matter, for any marker stain slide. So you can see that there is the IC image, a digital IC image, is processed, and there is a tumor cells markup for positive cells, with positive cells being red and negative cells being blue, and then a stromal cell markup, stromal compartment markup, again with red and blue for the negative and positive cells respectively. In the table that you can see the result, an example result of such exercise, and you can see that generally the results are fairly similar to what is done manually. And one thing I wanna say to start this topic is that at any steps in this process, slides are approved and analyzed by board-certified pathologists. So the image analysis of flagship biosciences is based at the fundamental level on a cell morphology-based approach rather than a pixel-based approach. And what characterizes our technique is the ability to separate cells by compartment, i.e. tumor and stroma, and the ability to identify immune cells not only as such, but also by subtype, whether they are lymphocytes, macrophages, etc. And this is an important point. This is done in general in the absence of subtype-specific immunohistochemistry. The other distinguishing feature of flagship is that we don't do a field of view approach. We don't practice a field of view approach, but we use a whole tissue analysis. And as I said before, pathologist review and approval is a multiple steps on every slide. So here I'm going to delve in some data. This is actually obtained from one of our publications, showing that image analysis can increase the confidence in biomarker scoring. And this is actually evidenciated very clearly immediately by the table that show that the inter and intrapathologist coefficient of variation are both much, much better for with the digital approach than with the manual approach. And looking at the chart, you can see the much smaller variation in the error bars. And particularly, I'd like to invite you to focus your attention on the fact that this is particularly true at the intermediate level of expression of PDL1, where often decisions point need to be evaluated. Okay. So in summary, we believe that to conclude talking about this, the flagship has demonstrated that image analysis technology is extremely precise and I would add accurate, overcoming the inner variability of subjective manual evaluation. So digital scoring, therefore, substantially reduced the variation compared to manual scoring by pathologists, as you can see in the much smaller coefficient of variation boxes in the both for interpathologist and intrapathologist evaluation. Now, there is another point that I'd like to make. As I said, this is related to the accuracy. So traditionally, you know, the accuracy of this digital method is evaluated in relation to the manual scoring of the pathologist, and that's still kind of the standard approach. But there is another way of doing that, which is evaluating the digital scoring and the manual scoring in relation to an orthogonal method. In this case, the method was nanostring. You can see that the correlation of the digital scoring was actually better than the correlation with the manual scoring. And I hope this increased your confidence in the adoption of the digital solution. Again, this is actually a different specimen with an example of the tumor markup and the TME markup with, again, negative and positive cells designated in blue and red, respectively, on the basis of a threshold that was chosen by the pathologist at an earlier stage of the development. After manually applying training regions, machine learning differentiated tumor and stromal across the whole slide. And then the positive cells can be quantified by each compartment. Another important concept that is made possible by the digital image analysis is the characterization or spatial interaction between cells and positive marker, and also immune cell interaction with the tumor and by themselves. That's actually is also been illustrated in one of our publications, in which we illustrated 4 different patterns of distribution of PDL1 positivity: the mixed, the induced only, the immune ignorance, and the constitutive, and the immune only. That seems to actually separate tumors in categories that potentially are more amenable to increase the predictivity of PD-L1-PD-1 interaction. Another advantage of our technique that I was trying to illustrate earlier is the ability basically to define and detect specific cell type in absence of immunohistochemistry. And the absence of immunohistochemistry part is particularly important because oftentimes when you want to interrogate this PD-L1 stain slide, you don't want to introduce any modification to the traditional staining protocol and to the correlated staining interpretation approach. So we have detected a way to illustrate where lymphocytes are present or not based on artificial intelligence. As you can see in the next chart, comparison of this staining with CD45, actually in particular, more specifically CD45 RO stained cells for T lymphocytes, was actually gave a fairly good correlation between the immunohistochemistry and the marker. On the left-hand side panel, you can see that there was also a very correlation between the CTA, artificial intelligence markup of the lymphocytes, and the CD8 markup of the lymphocytes. Another important problem is often to identify whether macrophages are stained for PD-L1. This is a particularly important topic, as the role of macrophages in tumor immunology and in tumor protection has been illustrated by several papers. So we actually develop a system to identify macrophages from tumor cells in using digital image analysis, utilizing basically combination immunofluorescence and immunohistochemistry on the same slide. And in the panel stained with the purple and brown cells, you can see a co-registration of the digital DAB stain slide and the fluorescent stain slide with false pseudocolor for CD68. In the next slide, you can see that after this method was used to develop the system and train the artificial intelligence of what constitutes a macrophages on the base of the CD68 slide, there was no need to redo this on a new court, and this is the court outside the training set. You can see that the model, the system had a fairly high accuracy, 93%. As you can also see into these slides, the macrophages as identified by CD68 positive staining and by artificial intelligence. They are virtually identical. Image analysis allows us to improve the IVD by allowing us to develop lockdown solutions and there increase the reproducibility and also eliminate the human error associated with the pathologist's interpretation. It is particularly important and particularly crucial that this error is reduced around the cutoff point that determines patient enrollment in a treatment or not. Now, image analysis can provide additional value endpoints in addition to improve the traditional score. Because using image analysis, using data analysis, we can explore endpoints that exceed the on-label scoring to better understand the outcome and inform future enrollment decisions. However, it's important to reproduce or build complex scoring paradigms digitally. And this slide will just illustrate the point that using our technology, we can reproduce pretty much any scoring paradigm, like SP263, Q2C3, or for either NSCLC or urothelial carcinoma. The data can then be processed using the traditional formula associated with each antibody and each indication, and basically reproduce completely the outcome of the traditional manual assessment, except that we're going to do that with better accuracy and better precision. So these are examples of some endpoints that add value to the monoplex IVD stain slide. The tumor stroma interface assessment can be calculated. The total lymphocytes present in a given compartment, the total macrophages present in a given compartment, and for each cells, one can determine the positivity or negativity status for PDL1. Nearest neighborhood, cell clustering, and more sophisticated assessment can also be achieved. And this is an illustration, a graphic illustration of how this will be achieved with tumor, stroma, and you can see that there are actually different colors that reflect the negativity, but also the intensity of the PDL1 staining. But also assessment of tumor stroma margin, defined as one choose to define, can be achieved. And then basically a table can be generated giving the details for each endpoint that is desired. So going back to the utility challenge and the fact that flagship image analysis approach can be combined with other platforms, this slide illustrates again this concept. And for instance, in the case of next generation sequence approach, one can, since that each approach has pros and cons, one can combine this approach and get the best possible words by achieving the best characteristics of each method, and therefore build more solid, more robust predictive models. An example of that is a recent cooperation between Flagship and Prednisone using a multinomic approach in which the unique gene signatures that could predict IC biomarker, in particular PD-L1 positivity and vice versa, could be interrogated. In summary, Flagship artificial intelligence tissue analysis profile every single cells in the digital image of the whole tissue section. Every single cell's morphology and the surrounding area is profiled in actually over 600 ways. So, for example, a tissue with 1 million cells, which is a standard number of cells for the average biopsy, would thus have 600 million data points associated with it. Using data science and machine learning techniques, we can group cells which have similar features together to describe phenotypically similar cells. We can then associate these phenotypes with patient outcomes and biomarker data to create a powerful comprehensive tissue profile. So in summary, working with flagship image analysis add value to the monoplex IVD stain slide by improving scoring reproducibility and reliability. The point I like to stress, though, is that this added value does not rely on any particular complicated test before the image analysis is generated. All we need is a round-the-mill PD-L1 stain slide. This allows us then to gain knowledge about important biological information in your tissue using, again, a previously stained or new slide without needing additional biomarker staining. And there is, of course, the possibility, as I hope I illustrated, of partner more multinomic approach for CDX opportunities to improve the quality of the data and the predictive value of the data. At this point, I'd be happy to take any questions you may have. Thank you for your attention.
Thank you, Dr. Giannani, for an excellent presentation on PD-L1 scoring using image analysis to help elucidate meaningful scores. At this time, we will open for questions. If you haven't already done so, please enter your questions in the question box. We've received several questions already, so for sake of time, let's get started on these. The first question, and thank you very much for your question, was, how can I get a copy of the slides? And I'll be able to take that question, Dr. Giannani. So please just fill out the survey at the conclusion of the webinar and let us know if you want to receive the slide deck. Thank you. Another question that came up was, what are the best practices in terms of reconciling potentially divergent IHC or other expression results for PD1, PDL1, and things like CTLA4?
Yeah, that's actually a very important question. And I think the answer is that the best practice is to use image analysis and basically utilize any of the scoring paradigm that one wants to interrogate in our reproduction digitally of the manual score. And this will potentially would allow meaningful comparison of different PDL1 staining and antibodies if one was interested in doing so.
Another question came in, and basically I think you've covered this already in the presentation, but I'll ask it for any further elucidation. How do you deal with the different assays, each developed for the different therapeutics?
Yeah, again, I mean, this is conceptually very important questions, but I think, the key to this is to actually reduce the intrinsic variability of each approach and then potentially investigate the comparison between different modality in ad hoc studies.
Thank you. Another question came up. Is there more false positives with manual scoring versus digital?
I think actually there are more false positive. I think there are more false positive and more false negative with the manual score than with the digital, providing that the pathologist do error or his due diligence in appropriately setting the thresholding of the staining. And the reason I'm confident in making this pretty brave statement here is that once you have actually set the threshold, there is not inherent variability in the evaluation of the threshold, which actually complicates the manual approach.
Thank you. Another question came up. Does this work for all the PD1, PDL1 assays? And have we had a chance to compare them?
Yeah, I mean, this actually does work for any PD1, PD1 assay that has a defined scoring paradigm associated with it. Or for that matter, one could create even his own scoring paradigm. We have actually conducted few studies in the past in which different approach, different staining and different antibodies were compared. And these studies are also available in the literature. In general, the result of the comparison for the different modality are basically intrinsic to the difference between the modality. But at the very least, the digital scoring eliminates the background noise, making these comparisons themselves more meaningful.
Thank you. There's a couple of questions that deal with pathology workflow, and I'll kind of go to them really quickly. The first one was, how is pathology review of the images or image analysis solutions conducted on samples received at Flagship?
So yeah, basically we have a very defined workflow in which the pathologists get together with the analyst, and then, depending on the time demands of the individual project and the turnover demands of each individual project, this is done in a few different ways. But essentially, the pathologists review the annotation of the images, so the part where non-analyzable parts of the slides are excluded, like fold or area of artifacts. Then the second assessment relates to the cellular recognition, so the ability to recognize cell as such in the appropriate number. And finally, the third assessment relates to the judgment on the appropriateness of the staining, what is called positive or negative, or even more in detail, what is called positive at different level of intensity. So those are the three mainstay of the pathologist evaluation.
Thanks. A follow-up question on that, and Dr. Giannotti, you're a pathologist as well, so this is going to hit home with you. Basically, will image analysis be able to replace manual pathology?
Well, I hope not. At least I hope not in my lifetime. But I think, in general, one has to hark back to the days of immunohistochemistry. When immunohistochemistry first was introduced, there was some anxiety among pathologists that immunohistochemistry will replace morphological assessment of the slide. I think at the end of the day, the pathologist's role is to interpret the data in the context of the clinical information. And I think any tool that provides more data to the pathologist not only does not replace her or him, but enhance his importance in the healthcare arena.
Thanks. One other question just came in. How are you able to distinguish between tumor and TME compartments?
Well, again, this is achieved by artificial intelligence trained by the pathologist. In other words, specific area of the tissue are actually chosen by the pathologist and the analyst together, and the artificial intelligence algorithm is trained to recognize this area according to a number of different parameters that the algorithms calculated. And I have to say that the tumor TME separation is one of the more solid portion of the digital image analysis paradigm.
Thank you. Another question came in. Is it possible to use this approach in liquid tumor biopsies?
Well, I mean, actually, to be honest, we haven't tried this approach. It's not easy to come to have a lot of access to liquid tumor biopsy. Now, I can actually, since we haven't done, I can postulate, and I could say if you have a scenario in which you had a lot of non-neoplastic cells on a slide, you would be able to use image analysis to detect tumor cells. But again, this is not an arena where we have done anything at this time.
Thanks. I think we've already answered this once, but the second question came in again, distinguishing tumor and stroma cells with computer image analysis. You want to bridge that again?
Yes, again, I mean, I think this is one of the best features of our system. It's fairly easy using an artificial intelligence approach as guided by the pathologist to identify stroma and tumor. And the way actually it's possible, the reason it's possible to train the algorithm is because the algorithm calculates a number of features, not only of individual cells, but only of relation of individual cells with neighboring structures to make that distinction.
Thank you. Just a couple more we have, and then we're still open for some more questions. Number one, how are you able to validate image analysis for LDT use?
That's an excellent question. And basically, we follow well, first of all, we validated, anytime we validated an image analysis for LDT use, we validated the corresponding wet assay. And second of all, after we've done that, we validated the image analysis using very rigorous CAP and CLIA, as in very rigorous CAP guidelines related basically to the achievement of sensitivity, specificity, and accuracy and precision. At this point in time, the mainstay on this approach is the comparison with the pathologist evaluation. So, at least for the time being, the pathologist is still the gold standard under which the validation approach is executed.
Well, thank you. One more question. Let's see. Can this be run as a clinical diagnostic tool?
Yes, this can be run as a clinical diagnostic tool, which we have done, providing that a full-fledged CLIA CAP validation is performed.
Excellent. That really runs through most of the questions we have, most all the questions we have. We'll give a few more moments for anybody else to submit a question online before we wrap up. But again, Dr. Giannotti, thank you for an excellent presentation on helping us to learn how we can use image analysis to elucidate certainly further information from using image analysis. So that's all for the questions we have today. Please note that we have recorded this webinar and you will receive a link to the playback tomorrow. If anyone has any additional questions or would like additional information, please fill out the survey or contact our webinar organizer, Ann Forte, who sent out the invitations. Thank you again all for your participation in this webinar. Dr. Gina, thank you very much as well.
You're welcome. Thank you, everybody.
This concludes today's webinar. Thank you for joining us.